today is actually letting you know you have all worked so hard on the quality project. And today we're going to be giving you a preliminary result report on what we have been our findings. And then we will be talking about what happens next for all of us today on the call. So with that, I'm going to hand this over to Katie, who is going to talk about the achievements that we've had under the SIM grant, the quality project results, as well as the Health InfoNet participation agreement. So with that, I'm going to hand it over to Katie.
Great. Thanks, Gemma, and hi, everyone. Happy September. I've been, as you all know, I was out of the office for most of the summer on a leave, and I'm back to work and very busy and happy to be back. And I was also really happy to come back to such positive results and information related to the quality project that you have all been working so hard on. So it's really great to be able to be here and present this information to you all. And then we're going to be talking about what we're now calling SIM Year 4, and you're going to hear all about that, many of you for the first time today. So go ahead, Gemma, we can get started. Okay, so some of these slides are a reminder and as we recap SIM Year 3. And some of you have been with the project the whole time, and it's amazing how fast years goes by. And for those of you that are newer to the project, so I wanted to have a few recap slides on here to really revisit where we started and where we landed at the end of this 3-year project. And so you all know that we've been working with 20 behavioral health organizations to really, for the first time, implement health information exchange services across your organizations and your various services that you provide. And then to really leverage the data to have some specific targets related to your patient and clinical workflows that you all specialize in. And then most recently, we've been focused on reduction of inappropriate or unnecessary ED utilization and really measure that using what we're calling an observational analysis. And we'll talk about that in detail today. As a reminder, we always like to give an update when we're presenting on how we're doing with different data connections. And as of the end of August, but this still stands true as of today, we have 13 out of the 20 organizations on this project live with data sharing, and the folks that are live are here. And so we feel really proud of that, and you should too. It's been a lot of hard work, and I told Rob Cook I was going to acknowledge him on this call today. He couldn't be on the call, but that he's worked really hard with your technical teams and your EMR vendors to make this happen. And it's still happening. It's still going on for those of you that are still in the process of doing that data testing and validation. We're continuing to do that work. So this work isn't stopping, but the success we've had, we want to recognize all of you for that. So on this slide, we're talking about just a summary in basic terms of where we're at with the milestones that have been a part of the project. I think those of you that are close to this project know these milestones very well, so I'm not going to walk through all of them. But we did, at Health InfoNet, our leadership team, Sean Alford, our Chief Operating Officer, and myself, Katie Sensei, we did meet and present to the leadership team at the Department of Health and Human Services here in Maine, who are who head up and lead up the SIM project and our contracts and our goals. And we presented many of the slides that you all are seeing today around really what did we learn over the last 2 years, what did we accomplish, what did we achieve, and so what are the ongoing challenges and work that could be continued. And we've all been talking a lot since our May webinar around sustainability. How does this work continue past the end of the SIM grant? And so we like to put things into tables here, and so these were our milestones. You see in green the outliers where we had hoped to be have everyone sharing data at this point in the grant, but we have some folks that for lots of different reasons are still struggling. Much of this work has been held up on the vendor technology side of the project, and you're stuck within the constraints of those vendor timelines and the different challenges they're having around growing this innovation. For some of the vendors, many of the vendors involved in this project over the last 3 years, this has been the first data sharing project that they ever achieved. And so many of us were in the position of actually teaching this group how to really do this work. And so we all learned and struggled through this together, and this is where we landed at the end of 3 years. And I think this conversation today is all positive and all about the hard work that everyone on this call and here at Health Infinite has been doing and achieving. So these numbers say a lot of success when it comes to us, and that's what we shared with the department. Okay, so this slide, and we talked a lot about this at the SIM presentation, and I know you and Gemma talk about this all the time, right, which is how are we doing with actual staff, users of the Health Information Exchange, really what do the numbers look like? And so on this, so Gemma and I worked together, and she worked with all of you to kind of give feedback on how everyone is doing on a monthly basis. The short greenish colored bar is just saying that those are the number of organizations within this project that had active users on their staff with accounts, accessing the clinical portal, and that includes the notifications work is within that. So you'll see that we've come a long way to where we started with our first users in May of 2015, and we have our August statistics here as well. And so you'll see we started with half the group, and we had really small numbers, and we worked really hard to figure out what were the appropriate roles, staffing programs. We had a huge amount of work around implementing consent for your clients in terms of what were their options, what were their legal rights, all of those really complex subjects. You see that timeline where that was the focus. That was the real focus, is getting that consent model in place so that your staff could actually do their jobs with the exchange. And then as the work progressed, and then we launched into the quality improvement project with our focus on reduction of unnecessary use and really working with those clients to get them better care and more appropriate services, you see the numbers get really much higher and much more focused. And so these are the average, so this is the total number of users per month that are really actively using the exchange within that month time frame. And go ahead, Jen. We also, on this slide, we wanted to help not only DHHS but all of you and ourselves really measure what's the population impact. How many patients or clients are we actually talking about here that are being accessed in the exchange? What does that look like? And so you see the same trend line here going up, and you see it spike in June, and then summer vacations hit, and we're still, continuing to experience that. We tend to see a seasonal cycle here as well when it comes to holidays and summer vacations, and so we aren't surprised by the dip between June and July, but overall the numbers have plateaued in a nice way, and we know that you all are focused on your clients that are the sickest and are the most appropriate use of our tools as you continue to expand the services. So it's really nice to see these numbers and to know that you really are having a population impact as you implement the Health Information Exchange tools in your practice. One of the things that Gemma has been really working on with all of you, and she's going to talk more about this when she takes over the presentation, but that is really important to leadership and policy folks that are looking at the larger population impact and healthcare reform policy decisions, is really around what are the workflows. what is really changing in terms of how care is being provided when health information technology tools are implemented across the services you've been able to do that in. And so what Gemma's been doing and what we've been then, trying to squish into a slide, which we know is not an easy thing to do, is to try to present what are the biggest takeaways related to what we call data-informed workflows. And so you'll see them listed here. These are not a surprise to you all because you all are the ones doing the work, but I left this slide in the presentation because I wanted you all to know that we spent a great deal of time talking with leadership and policy folks here in the state of Maine, as well as at CMS on the federal level around what really does this work mean. We saw the numbers that we just showed you. Well, what does that really mean to you all and your staff and to the clients that you serve and their outcomes? And I have to say that I'm really impressed by our state's follow-up questions related to this slide and some of the other slides related to workflow. They're really interested to understand, well, what are the staffing roles that use HIT or health information technology? Who actually has been using this? And so Gemma's going to thank you and talk to you about this later in terms of what we're doing to look ahead related to workflows and roles in your organizations. But she's been able to collect information from all of you around what are the roles in the staff positions and how do they use the tools differently or similarly, because there's lots of similarities across the organizations that Gemma has seen, but there's also some unique things going on across the organizations that we hope to share and spread going forward. So anyhow, we'll be continuing to come back to talk about this concept of data-informed workflows heavily going forward, and we'll talk about that in a few minutes. So much like the last slide, this was the other slide we talked about. We continue to talk about value and workflow, and I think that the real takeaway for all of us here, and I would say it's fair to say for the leadership team governing SIM as well, is that the real value of providing medical information, hospital, primary care, laboratory data, all of the data that your staff is leveraging is really for the first time, in Maine at least, we can say, it was really the first time to bridge that huge data gap between, quote, the healthcare delivery system and then behavioral health, which you all have really been in that silo, and there's been so many barriers to you all getting the information you need. And so when we talk about behavioral health homes and that policy model, I think what we all learned really quickly, and then it continues to show, is that when the policy and the care model shifts and aligns with what data and health information exchange information you have access to, you really are able to change the workflow and the care planning and the direction that you can take with your clients. And so these are just some this is a very short list of examples of the things and the themes that we've heard over and over again around what's the value of having access to that medical data when you're working within that behavioral health silo from the larger system. And so we know about this, we've talked about this repeatedly, but it was a huge takeaway for those that have been on the outside of the project to understand that value and what you can really do when you have a behavioral health provider that has the full access to information going on with that client outside of their care. Okay, so I'm going to shift gears a little bit now to kind of coming back to the quality project. We have asked all of you since January 15th, I think to be exact, Gemma, to work really hard on a very focused project using our real-time notification service, which is part of our health information exchange toolkit. And it's been a lot of work, and we know some folks have struggled more than others to really find the staff time to make this work happen. Even though this has been a reimbursement project for your investment, we know that your time and your resources always goes beyond whatever a grant or reimbursement project has. And so we've always been thankful for your dedication to that. And I think the quality project was a time-intensive project that you all took really seriously and dedicated yourselves to. And so today is really about thanking you and showing our preliminary results, and we'll talk about what preliminary means in terms of our data analysis. And Sean's here to back me up with any data-related questions for you data folks on the call as they come up. And so this is really a celebratory presentation, and we'll show you why in a few minutes, and we're really excited to talk about it. We did present these same preliminary results again to the STEM leadership team at DHHS, and that was a very positive conversation and has led to what is now the continuation of STEM in year 4. And so the outcomes that we are seeing in the next few slides related to your quality work are really directly related to the energy that the state has and CMMI has around continuing this work to continue to add value. As we learned that STEM would be allowed to continue for a 4th year, that really got us thinking about this project and what could we do to keep this awesome work going and to keep you all engaged as we renew and start a new contract cycle. So we're going to talk about all of that, but I say that now because it's really strongly related to the success you've had on this awesome quality project. So let's keep going. Okay, so some of these slides will be, well, the next few slides will be new for everyone, and some of the language we're using here is really more aligned to the federal grant language, and so some of this language is new for you all too. We didn't talk about the quality project in terms of a hypothesis and that kind of more scientific terms related to any kind of study, but I thought that it was important, well, we all thought it was important to bring the slides that we showed to leadership to you all so that you saw what we're talking about. We also will be, for those of you that attend the STEM Steering Committee, I know a few of the organizations on the call do participate in STEM Steering Committee. We do have the meeting next Wednesday on the 28th in Augusta, and all the organizations in our STEM have been asked to present kind of conclusions and at a high level, because you don't get a lot of time, so you have to keep it pretty high level, but what were our big conclusions related to the last 3 years. And Sean and I will be present, and we will be talking about this same presentation with that wider community as well. And so I think it's great timing that you all get to see this information today, and then it even gets distributed to a broader group of people next Wednesday. So for the sake of what we're calling our observational analysis, we have our hypothesis here, where that if we have interventions leveraging our real-time notifications and the information related to that, that we'll see an overall reduction in unnecessary ED utilizations for those clients and patients. We interchange, as you all know, clients and patients, so you'll hear me saying that. We worked with you all to target folks that had 2 or more ED visits over a period of time, and we leveraged our access to Medicaid claims data to complement the clinical data to make sure that we provided each of your organizations with a list of clients that then you could give us feedback on and determine who your target panel was, per se, for the quality project and the interventions you would then do. What we started with was a list of about 800 plus patients that we provided to all of you, and then you rightly so whittled that list down to the folks that you knew you were actively caring for and were going to continue to be your patients. We all know patients come and go from your services, so we had to focus on the group that were truly your client base. And then 2 out of the 20 organizations couldn't participate in the broader quality project for different reasons, and then we worked separately with you all. So what we're going to present going forward is really the work of 18 of the 20 organizations participating. So that really sets the stage of the foundation of the project. And now what we want to do is talk about the study and the data related to what led to our conclusions, at least our preliminary conclusions. And then we'll talk about STEM year 4. So go ahead. Okay. So Some of the data on these next few slides I'm not going to get into at a detailed level because I'm not a statistician, and I'm pretty sure no one else on the call is. So we'll keep this as high level as is appropriate. But if there are questions related to the study at a data perspective, please use the chat box, and then we always can do email follow-up as well, because I know some folks are more interested in this data than others. So data used, I think this has been pretty clear all along, but not for everyone. So we continue to receive the main care claims files, and so we have that as a data set that we continue to use to help us understand what's happening with the clinical data in our clinical data set. And you'll hear us use the term CDR, which is our clinical data repository, which basically is all of the data that sits behind the Health Information Exchange portal that you and your staff use to access. So we're using claims data to support the study. We're using and the clinical data, and then we're looking at what was going on with your staff in terms of how they were accessing patients and how did that apply to the outcomes of the project. From a time frame, when you see our pre-intervention period, it was from April of 2015 to the end of September of 2015. And then the post period, which is really when you all were doing this quality project, was from January through July 15th. For those of you that were involved, you know that very well. And what's the intervention? We talked about that using real-time notifications in workflows. And this is just a slide that's really for external viewers of everyone who participated in the pilot. So go ahead. Okay, so now we're going to get into the preliminary analysis and the results around that. And again, this is an observational analysis study. So for those of you that have questions related to research, validity, and things like that, I'll probably ask Sean to answer those if they come up. Okay, so at a high level, we were really interested in what was the change between any staff, using the Health Information Exchange to care for this patient cohort. And so we have the pre and post. And so prior to the quality improvement project, you see the number of staff users that were looking this client cohort, the 443 patients, up in our portal. And obviously, I think it's logical, but the data kind of proves that you all, in particular the behavioral health community, which is you all on the call today, had a huge surge in really accessing these clients because of your focus and your use of notifications and your focus on this interventional work. And so I think this just shows what you already know is the obvious, but it's really important contextually for the rest of the study. Okay, so this is a pretty statistical explanatory slide. But what our team did here, our data team here, was they looked at the difference between what we collect in our clinical data repository, which is what CDR means in the slide, in terms of what were the, quote, what we call an encounter visit in our data set compared to visit days. And we compared that information really to just help us set a baseline in the analysis to make sure that our encounters versus our visit days were somewhat aligned and comparable. And what it did is it told us that they were, that those two data sets were comparative and close enough that it allowed us to then proceed with the results that we're going to show you. So this is really a background slide. And I don't know, Sean, if you have anything else that's important to say about that. It's really, to me, this is a background slide to what this audience really cares about. Okay, so I'm gonna spend more time on the next few slides. Okay, so the EDR visit days, if you think about the client group, and again, these slides are about the client group that you intervene with, the 443 patients. When we look at claims data on the left and our clinical data here at Health InfoNet on the right, that's what you're looking at. there was overall a reduction in 35% in what we define as ED visit days for this population that you are working with. And we'll talk about what does that really mean in the next few slides. Okay, again, so patients with ED visit days, overall, there was a 30% reduction in patients having ED visit days in the post-intervention period. And you see claims data on the left and claims data on the, clinical data on the right. And so what you're seeing is consistent analysis of saying that ED utilization is going down. And go ahead. And then we, here at Health Infinite, we applied the statistical mean data to looking at the pre-intervention period before you started the project and the post-intervention. And so this is another way to look at what was the overall average decrease in the number of visit days folks had going from one period where you weren't using the portal to the next period. And you see in both interpretations, you see a decrease in visits overall, pre and post. Okay, visit charges. So this is where the conversation starts to get meaningful from a policy and a Medicaid reimbursement and planning perspective, is looking at charges to Medicaid. So when you see money and cost here, be thinking MaineCare, because that's what it's about. And what we're able to do is compare what are considered ED visit charges in the pre-period to MaineCare and in the post-period. And you'll see the decrease in this calculation of just under $400,000 in this period of time for this small group of clients. And so I think it's, when you start thinking about applying this study and this work to a broader set of clients, or even, wow, there's a lot of opportunity, you know, this was really one small group of clients, and look at the very positive change you have when it comes to talking about charges for the ED specifically. Now, what I would say, and we talked a lot about data caveats with DHHS, but what I would say is that what's important to know is that when we look at claims data, which is where the charge data comes from, you can't easily, at least we don't have the kind of data access where you can easily associate ancillary charges such as pharmacy or consultant, other facility type charges. Sometimes there's ancillary charges that are beyond the hospital charge, and those of you that work in that charge world understand this well. You can't link it necessarily to that ED visit. So what this is really focused on is the very specific ED charges that are very clear in the claims files. And so this number could be well understated, but when it comes to what the data clearly and consistently shows, this is a reduction that we were able to quantify. And so I think that's a very positive number for anyone who's trying to reduce unnecessary costs in our healthcare reform efforts to see and learn from. Go ahead, Jen. Okay, so at this slide we spent a lot of time on talking internally and externally, and this is a preliminary number. I mean, all of these numbers are, but what I want to say specifically about claims data, and I think all of you know this, that claims data gets updated every month as cycles of charges run through. You know, some folks are delayed from charging, sometimes errors are made, but the data gets cleaner and cleaner as the monthly cycles go forward. And so we do expect this number to change that we're showing on this slide, but overall, we looked at all medical charges data. So again, this is not pharmacy data. So we looked at medical claims files for Medicaid patients for your 443 patients you were intervening with, and overall saw a total, this was as of our August data, overall we saw 34% less in utilization and charges for all medical utilization. So this is looking at not just emergency department costs or emergency room costs, but it's all utilization, and we see this decrease. Now, there's lots of questions of what does this really mean? So you can't draw direct conclusions from this information, but it's a very positive and compelling data set that says okay, what else do we need to study? What else do we need to learn about this work that you all and we here at Health InfoNet are doing? And so we see this really positive turn, and you would very quickly, at least I do, I jump to conclusions such as, because I know all of you, well, if you have the right care at the right time, you're going to get, overall, you're going to have less cost because you're going to be directing people to the places where they truly need care, and you're going to be avoiding that unnecessary cost. But I can't draw that conclusion from the analysis, but that's how I think about it, and I hope that what you see from this and what you walk away with is that you are making a very positive difference in the right direction with the clients that you've been working on throughout the quality project. And Jen will continue to talk about that. So going forward, one of the things that I'll be talking about is SIM Year 4, and what does this mean? And before I start to transition, Sean, is there anything you wanted to share with everyone about just our experience with the department and sort of the perspective of how folks reacted to the data and how everyone's thinking about it going forward?
Sure.
I think that would be helpful.
Hi, everybody. I can't reiterate enough how important this data is, how important it is that you're all engaged in helping us bring this forward. This is information that from a analytics and from a research perspective that we've been making the argument at Health InfoNet on for many years, but even more so the behavioral health community nationally has been making an argument for. And we've been working with government agencies like SAMHSA and others to try to make the case that if we provide tools, if we engage the behavioral health community where they are and give them information, then there's an opportunity to really talk about integration at a whole new level. And what this data shows, while it's observational in nature, it starts to quantify that in a way that nobody's done, to my knowledge, to date. That's what the department heard, and that's really good. If you think about the majority of your budgets being paid for by Medicaid, the Department of Health and Human Services, they're seeing that, wait a minute, if we invest in this, we can see significant savings. At the same time, we can see improved quality of care. That's the argument that this data begins to help shape from a policy discussion. And we've had the opportunity now to talk about this with the commissioner staff. The commissioner has seen this data so far, from what I understand. And we're going to, as Katie mentioned, she and I are going to present this to SIM Steering next week. Everyone in the room was floored by this, number one. We had data people in the room, and we're able to articulate in a very detailed manner what the data says and what it doesn't. And Katie was correct. It's an observational study. All we're doing is saying, hey, there was an intervention we had, and we looked at the data pre-intervention and post-intervention. There are clearly other factors involved, but the difference is significant, and that's what makes it real. We're going to want to study this more, and as we move forward in SIM, what we call now Year 4,
yeah.
That's part of what the department would like us to focus on, and they're ready to invest some money in it, and that as you know, the budgets are really tight. It's really challenging for the state government to do new things, and yet they're really focused on how do they innovate in this space and how do they help you accomplish your goals. So I think that's the message we're hearing, and we're not only hearing it when they speak to us, we're starting to see it come through in written documentation. And when I say written documentation, I'm saying that they're starting to sign contracts. And that's going to benefit you. It's going to benefit Health InfoNet. And I think over time, what we'd really like to do is disseminate this nationally, because that's the message. We want to start sharing this broadly so that not only our state's government can hear it, but our federal government and SAMHSA start to hear this message. And as we're starting to see investments in health reform, we can start using this information to help to inform the discussion.
Great. Yeah. Awesome. Thanks so much, Sean, for your perspective. I think it's a really exciting time, and really great to have the opportunity to continue. So we're going to go through just a couple more slides, and then we're going to talk about what the opportunity is for Sim Year 4 next. This slide around caveats around the analysis is important for folks who are trying to understand in a more detailed level the study and how it was performed and what some of the outliers are related to the data analysis. And so I'm not going to go through that. I left it there for those that who are curious about that and had more questions. I just left it there for that sake. So go ahead, Gemma. Okay, so Sean has alluded to some of this already, but in terms of opportunities for continuation, the ideas so far are still being solidified, but what we've talked about so far, continuing into Sim Year 4, is addressing some of the data analysis components of the study, and then continuing the study out so that we have a full 12-month period of intervention. And so we're going to talk about what that means to you all in a few minutes, and then to continue to work on cleaning the data up related to risk adjustment and other important analysis whenever we're looking at claims data in particular. So go ahead. Okay, so I wanted to, we've talked about this earlier in the year, I think back in May before I went out on leave. We talked about what would all be coming to you this month. So this is a reminder for those of you that remember this, and for those of you who are either new to the call or didn't hear this prior to, this is what our process is going to be in terms of contracts really continuing. So there's two contracts that you all have been under with us. One is the participation agreement, which is what we have with every client and every provider organization that shares data with the Health Information Exchange. That terminates on September 30th. So, and what we had said is that you'll be receiving a new participation agreement that has the pricing exhibit that we presented in May also for the per member per year cost estimate, and we'll be getting all of those out to you. You see a due date of October 1st. We know that not everybody can turn around the contract by October 1st, and that's okay. Services are going to stay continuous, and our work with you will stay continuous regardless around that contract timeline. It's just in there for hard facts, and for those of you that get it back, great. This contract, once you sign this version, it has, it's really what we call an evergreen contract, so it auto-renews going forward unless we hear otherwise from you all, and then the appropriate limitations apply to closing down a contract if that were to happen. So hopefully this is the last time we have to put you through the legal process for a little while anyways, and then you know that things are good to go on this side. The second contract you all have been operating under with us is really a project contract. That's what I like to call it. But it really just sets the terms of the milestones and the reimbursement dollars that you all have been executing. What we have been given the opportunity to do through SIM funding through the state is to extend that contract for another year. And so we weren't sure if we were going to be able to do that, and over the last couple of months, folks have been talking and getting that all worked out so that we could continue this work with you all. And so we are kind of announcing to you all for the first time officially today that we are able to continue our work with you in a more focused capacity for SIM Year 4. And what that will allow us to do is basically, we're going to do a contract amendment to your current project contract, again, separate from the participation agreement, that's really related to, for those 7 organizations that haven't finished your data connection, you'll be able to continue that work and then continue to invoice and pull down those funds, those reimbursement funds, as you accomplish those milestones, for those of you that haven't been able to do that yet. So we want to keep that IT project going with Rob and finish that and then pay you for that. And likewise, for the quality project, Gemma will be talking about how we're going to invoice and close out the payment for the quality project this month. Our other hope, and I'm going to talk about this on the next slide, is that we want to, what we're calling expand and continue the quality improvement work and project with you all. And so I'm going to talk about that next, but that's the hope. The hope is that all of you continue kind of business as usual with your staff and using the Health Information Exchange as governed by the participation agreement, and then you would continue in a more focused capacity with very specific milestone deliverables and continued reimbursement through SIM Year 4, and I'm going to talk about that on the next slide. Go ahead, Jen. Okay, so this work is literally in process right now in terms of the SIM Year 4 contract and scope of the work. What I'm sharing with you today is what I know to date, and then we're going to be obviously really quickly and rapidly getting the details out to you all as contracts and scopes of work are finalized. So our opportunity is to continue the HIE subscription and use of notifications. Again, kind of a business as usual concept, and of course growth if folks are continuing to spread and implement HIE, that's of course fine. To continue the quality improvement project, to continue with your interventions, and what we do know is that we will have a continued focus on ED reduction in the same scope that we've been doing it in. What we do know is that we will have reimbursement for each organization. What we don't know is what that total dollar amount is yet, and so I don't even want to put a dollar amount out there and then get anyone disappointed or likewise. So I am not able to tell you the total amount. So we're going to let you know that in very specific details hopefully over the next week or so as we get out the new project contract amendment to you all. But I think the positive news is that there is the department and the state and the feds supporting this work all understand the value of having the reimbursement to invest in this very specific work, and they wanted to secure funding in this fourth period to continue that work above and beyond the current funding that you're already promised and being executed. So that's really positive, and what it really speaks to is the value and the success that you all have had in completing this project. So very soon I hope to be able to share what that dollar amount is with you. I hope to have it today, but I don't. So we'll be getting back to you on that. So that's at a high level what we hope to write into a contract amendment with you all, and we're hoping to continue to have the privilege to work with everyone and continue to make a difference in your clients' quality of life and health. Okay, so just to transition over to Gemma, again, next steps, we're going to be working with you on the two contracts, the participation agreement and the project extension. And Gemma's going to be following up with everyone on the invoices that have been completed for the quality project, and she'll explain that in her slides coming up here. And then the last thing I wanted to say is that back in the spring, everyone sent Gemma estimates on annual clients served. We know that that can shift drastically over a few months, especially if you stop providing a particular service or program, or you add a brand new service or program. And so we know that you all are dealing with a shifting framework here, and I know that a lot of program changes have happened over the last few months as folks have let Gemma know that. What we will be sending you is a participation agreement that has a price cost exhibit based on the last estimate you gave us of the annual clients served. We'll use that. The document you're getting is a Word document, and so you can make edits and changes to the price exhibit based on the client served. We just ask that any changes you make, you use track changes, and that you highlight that in your response to us as we discuss that with you all. I think that's just the simplest way to do this. So we'll be looking at that. If anyone has, again, any questions or needs to revisit that question around the estimate of annual clients served, Gemma is happy to talk about that with you. I'm happy to talk about that with you. We did go through this, but it's been a few months, and so if we need to revisit that, we're happy to do that. So Gemma will be working with everyone via email. This coming Monday is when we'd like to do it, and get you started fresh on a Monday morning with the contract information you need in your hands, and then you can then start the process of getting that step reviewed and signed when completed. So those are really the next immediate steps, and then Gemma's going to talk about some of the finer details and talk to you a little bit about what you've accomplished. So thanks so much for everything and all of your hard work, and I also would like to just take a moment to recognize Gemma for all of the hard work you've done and really dedicated, full-time, head down, really working on the details, working on our educational materials, our communications packages, tracking all of this data, working with everyone across all 20 organizations to make sure everyone has exactly what they need to make this work happen. This project wouldn't have happened without you and your dedication to making a difference in clients' lives is what I know motivates you and keeps you waking up and coming to work every day. And so I think it's a really rewarding experience to watch you go through that and really actualize some of the reasons you came to work at Health InfoNet six years ago. Oh my goodness. And also, today, you've been working at Health InfoNet for 6 years.
Oh, really?
Yeah.
Oh, my.
I know that. I remember that. But so coming from a clinical background in behavioral health yourself, and then understanding the value of HIT and now working here and then having 6 years under your belt of experience is quite something. So congratulations.
Thank you, Katie.
And thank you.
Thank you
so much.
Turn
this back to you.
Thank you so much, and thank you, everyone. I can't tell you what a privilege it's been to work with all of you. I have made no secret over my biased behavioral health, and it has just been such a privilege to work with every one of you, and to really, I have really loved being able to show everyone what a difference all of you make, and that's been such a privilege. And Katie went through the numbers, and there's truth in numbers. I don't care. Anybody else can try to stand on their head and tell me that behavioral health is not the primary provider for these SMI clients. They'd have a hard time convincing me, and they'd have a hard time convincing anybody that looks at the numbers that Katie was showing earlier. So that reflects your hard work, which you have been doing prior to Health InfoNet coming on board with you. We're now having a platform to showcase how great you are and the work you do. So thank you for working with us. And look at the difference that a year makes. So I wanted to look at May, June, July, and August of a year ago, and look at, these are the lookups per month, and May, June, July, and August of this year. And when you combine the lookups and having real-time medical data and what you guys do with the medical data, the outcomes speak for themselves. And that's what this is all about. So yay, keep up the good work. And now that DHHS has been appropriately impressed, may I say, and we do have this extension, it's an opportunity for us to continue the work. And what really has been so wonderful for me, and I think for everyone else on the calls, has been to hear the stories behind the data, that there's amazing data points that we're talking about, but each of those data points represents a person that you know and that you know is suffering and that you've gone in and you've made a difference. And so this is really, really good. So thank you for doing that. And so we're looking forward to another year of the SIM extension, so SIM year 4, and you're probably wondering, what does that mean to me, and what's next, and what are some of the details. And so did want to let you know right up front that from the user side, nothing's going to change. We will continue to support your behavioral health home goals for quality improvements while reducing the cost. It's not going to look different for your end users. And they will continue to look up, your staff will continue to look up their clients in the clinical portal as they always have. They'll continue to do the specific interventions that each organization has identified as part of your mission of your organization. You'll continue to do that. And so that's on the Health InfoNet end. In terms of reporting, we're going to have a new monthly report for you, and it's going to be about the data-informed workflow that Katie had spoken about earlier in reference to DHHS has an interest in knowing a little bit more about the workflow and who's using it and how they're using it. And so we will be preparing a new report for you based on the work that you did on a report that you submitted in July on the behavioral health organization usage of the clinical portal by staff role. Now, we went through in that particular report, we went through all of the different interventions, and we listed several different staff, and you just did an X to identify which staff did what intervention. And what I found in going through everything was that if you take away the staff role of the administrative assistant, is that each staff member did everything if I looked at you all as a comprehensive group. And so it was very clear to me that it was very different per organization. So what we're going to do moving forward is try to capture more of how your specific organization captures by staff role using their workflow to go into Health InfoNet, because that can then give us the information. We have some data gaps in this report, and we want to fill that in. And we want your staff to be aware of how much they are part of this project too. So that's going to be part of our work in the next year. So coming soon, a new monthly report. In the next couple of weeks, we will be developing that and getting that out to you. And again, it's something that we want to make easy for you to complete, but to give us the data facts that we need for DHHS. We will also be, moving forward, sorry. We will also be continuing our monthly webinars, and there's going to be a focus on usage by role. And one of the things that we're going to ask you to do is bring different staff by roles to the webinars, and we will let you know in advance who it is that we need. So for the next meeting that we have, which is October, we want to focus on case management. So I will be in touch with each of the organizations, to my contact person, find out who you will be taking with you on to the next webinar. So in addition to leadership, we do want case management at the next webinar. We will be focusing on different webinars on different staff roles, and that's to go along with the work with the data workflow. So summary, we're going to continue with that quality project for the next 6 months, same panel. The monthly report will change, a new report coming soon, and the monthly webinars will continue. So we did want to give you a big congratulations on that. Job well done. Thank you so much, not only from Health InfoNet, but to on behalf of your clients, what that represents in terms of reduced suffering and sort of a better sense that you're there in their corner. So well done on that. We will be this week sending you, actually it will be coming from me, so please my contact at each organization, keep a look for an email from me in your inbox regarding milestone 3.3 payment. So please submit back to me the invoice and the completed 3.3 report, and we will get you that last milestone payment. So just congratulations, everyone, and job well done. And now we have some time for questions, if anybody has any questions.
Margaret, if you're still on the call, we're going to follow up with you an email to your question. It's a little detailed. So we'll get back to you an email, and if it applies to other folks, we'll share with everyone else. So thank you. We've got it.
I think that's it. Any questions coming in?
Yeah, there's not any additional questions, so we'll follow up. And so thanks so much, everyone.
Thank you, everyone. Have a wonderful day. Appreciate all the work you've done, and I'll be in touch. Thank you.